I would say going beyond brain mapping for medial temporal lobe tumors, how do we apply the anatomy to remove tumors in the medial temporal lobe? As Professor Rhoton would say, the brain is the jewel of creation, and we want to be able to preserve as much of the brain as we can in our operations. Every part of the brain should be respected as much as possible when we perform resections in our operations. I want to start by, remembering this very important paper that Dr. Ture published, already 20 years ago. Imagine that. And this paper influenced me very deeply, as I think a whole generation of us, because it was a paper that shows us how to start learning about the anatomy of the brain. Probably as it happened to me, many of you, I was disappointed when I was going to the operating room as a junior resident, and I was seeing brain surgeries done without understanding of the fiber tracts or what was going inside. Everything was looking the same. But with this technique, we were able to actually understand some of those connections and the anatomy, intrinsic anatomy of the brain. And that stimulated many of us to start doing fiber dissection studies. And at the same time, we started doing also fiber tractography studies. DTI started about that time. So it was a perfect time, perfect coincidence of the initiation of or reinitiation of white matter dissection studies and the beginning of fiber tractography as an imaging technique. I put this picture here because someone in the audience was asking about the arcuate fasciculus and the connectivity. And we studied this in the lab, doing dissections and correlating with fiber tractography. And we studied the difference between right and left hemisphere. And we actually got a very large database. This is a template of 500 subjects together. And you can see how they are clearly asymmetric. You see the thinner one is the right side, the thicker one is the left side. So there is asymmetry in the arcuate fasciculus, and that relates to the role of this tract into language function. Of course, it's not the only tract that is relevant for it, but it's a very important player in the language system. There are other tracts that are also interesting and controversial, and there is the inferior fronto-occipital fasciculus you heard about, and we also studied it and different segmentation patterns. But I wanted to go back and say, should we call this the inferior fronto-occipital or just the fronto-occipital fascicle? If you may remember, Dr. Ture's actually first paper on the superior fronto-occipital fasciculus was an anatomical study showing that fasciculus doesn't really exist. And years later, we actually did this study with fiber tracking just to corroborate that with imaging studies. It demonstrates that the superior fronto-occipital fasciculus does not really exist, at least the way it was described. So important anatomical research. But when we talk about the temporal lobe, of course, we also care about the optic radiations. And you see this nice dissection here with the optic radiations and the correlation with fiber tracking. And you can look at the amygdala in front of the optic radiations. And you can see this is the view from the ventricle. And if you look at the amygdala and the location of the optic radiations, you can realize that if you're going to go into the temporal horn and you want to preserve the optic radiations, the best way of doing it is going from the front, going from the amygdala and from the lumen insula to get access into the temporal horn without disrupting the anterior part of the optic radiations. Also look in this dissection at the optic tract as a very important landmark when you're doing your operations. The optic tract represents your upper limit of your surgical resection. Years ago, we put this paper together. We review all these fiber tracts and correlate them with fiber tractography. But we also studied, as Julio showed, the anatomy of the medial temporal lobe. And it was Professor Evandro Oliveira who divided the medial temporal lobe in 3 segments: anterior, medial, posterior, in a didactic way to decide which approach to use for each area. And we have studied the different approaches also in the lab and how to approach anterior, medial, and posterior segments of the medial temporal lobe. The medial temporal lobe has an extraventricular component, which you see here, but it has an intraventricular component, and that's why it makes it so tricky. Understanding the correlation between intra and extraventricular components is not an easy task to do, but here you can see the anterior part of the medial temporal lobe is formed by the uncus, and the uncus has an anterior segment, which is the amygdala, and a posterior segment, which is the head of the hippocampus. Then the middle segment is the body of the hippocampus, and then the posterior segment is the tail of the hippocampus and the atrium. So when we look at the anterior segment, we can look here at the extraventricular surface. We can look at the uncus, and we see the prominence of the amygdala anteriorly, and then the head of the hippocampus, the extraventricular portion of the head of the hippocampus that we're going to find in surgery. And a key anatomical landmark is the uncal sulcus, because the arteries are going to go into the uncal sulcus, as Julius showed, and we need to find those arteries, dissect them, and coagulate them when we want to remove tumors from this area. As we move posterior, we can see the body of the hippocampus, the extraventricular portion with the fimbria and the dentate gyrus and the subiculum, or the part of the parahippocampal gyrus, and then the fimbria that separates or connects the fimbria, the choroid fissure that connects the fimbria or separates the fimbria from the thalamus. And opening this choroidal fissure is another key step when we do surgery on the medial temporal lobe. So we need to also understand the microvascular anatomy, and you showed very nice examples just before me. And the anatomy of the uncus is complex because there are 3 different arteries contributing to the anatomy of the uncus, to the vascular anatomy of the uncus. We have the choroidal artery, but we also have the middle cerebral artery giving branches to the outer surface of the uncus, and then we have the PCA giving a strong vascular supply. And remember, the choroidal artery and the PCA give branches that go into the uncal sulcus that need to be identified. So here we describe the different vascular territories for MCA, anterior choroidal, and PCA at the level of the uncus. This is a work that I did together with Professor Evandro de Oliveira, mostly focused on understanding the vascular anatomy for AVMs, but also applies to tumors in this area. So again, the uncal sulcus, we are opening it here. You see 2 arteries going in, one from the choroidal artery, uncohippocampal artery, one from the PCA, the anterior hippocampal parahippocampal artery. And in this other specimen, there is no branch from the choroidal. It's all coming from a very strong hippocampal parahippocampal artery from the PCA. And you can also see the venous drainage of the hippocampus. So in this is a temporal insular glioma, but I'm just going to show you the very last portion where we are removing the head of the hippocampus that is bigger than normal because it has a low-grade tumor inside. And you see we are opening there the choroidal fissure. And as we open the choroidal fissure, we need to continue the disconnection anteriorly along the uncus. And we need to find the brainstem medially and respect the arachnoid. So here we see the fimbria, and I'm going to continue opening the choroidal fissure where I can see the choroidal artery, as you see right there. And as we keep disconnecting the uncus posteriorly, we find right there the uncal sulcus, and that's the branch from the choroidal artery entering the uncal sulcus that we are right now coagulating and dissecting. And now we can follow the choroidal artery into the choroid plexus. We need to preserve the choroidal artery, of course, and just coagulate selectively the branches going into the hippocampus. That one we just coagulated, that's a branch from the PCA going also to the uncal sulcus and anterior hippocampal parahippocampal artery. So it makes a big difference when you do these operations to understand the microvascular anatomy. So you can do a very meticulous operation where you disconnect vessels in a selective way. We also talk about the anterior choroidal and the lateral posterior choroidal artery, the basal vein system, and the variations in the venous drainage that we reviewed before. It's very important to understand basal vein variations, also for skull-base surgery, as sometimes this basal vein can drain into the tentorium. You need to be always looking for that, or it can drain into the inferior petrosal vein. Those are rare variations, but they can also drain anteriorly, the whole basal vein system. So all those variations need to be understood well before you do your operations. So I'm going to show you some case examples, and this is a young patient with a history of radiation in the past, and you see he has a tumor on the uncus of the temporal lobe. And this patient presented with seizures. And if you look at this tumor, some brain tumor surgeons are going to recommend going a transcortical approach to this tumor. They call it a transcortical equatorial approach to the tumor. And this is a type of procedure that I do not like, because you have to cross normal brain to get into the uncus, when you have a much more elegant way that is not only elegant, but is a way to preserve a lot of the temporal lobe without disrupting any. And the temporal pole is actually an important part of the brain, and it's good to keep that intact as much as possible. So we prefer to do, as Professor Jasanki described many years ago, a selective approach to the uncus. And this doesn't require any brain mapping. There is no mapping involved here, because you're going to go directly to the uncus and there is no function to map in that area. However, you need to understand very well the microvascular anatomy on this region, and be familiar and comfortable with microvascular dissection. So this is opening the sylvian fissure carefully, and it has to be a wide split, and you need to be working around the MCA branches. And as you will see, there is always very often an inferior insular vein that you can use as a landmark at the level of the inferior insular sulcus. There is also often an early temporal branch, as you see right here, that is in your way to the uncus, and you need to carefully mobilize this artery. If it gives some supply to the uncus, you can take those little vessels because that's going to the area of the tumor. And you can see that basal vein draining anteriorly to the inferior insular vein connecting. So we need to keep opening. But the beauty of this is that you can identify, for example, the lenticular striate arteries. And those are very important arteries to identify, because they form the roof, the upper limit of your resection. And I like to see them so I know where they are and I know how to preserve them. I like to also see the third nerve and dissect the arachnoid of the third nerve so I can separate the uncus from the third nerve. So this is an operation that is done extra and intraaxial. Extraaxial because you go around it, define third nerve, define the lenticular striate arteries, then intraaxial because you go into the tumor, into the temporal horn. Once you have the anatomy displayed, then you can start entering the uncus and the amygdala, also a little bit of the planum polare, but you're going to restrict how much you go posteriorly to prevent injuring the optic radiations. And I can attack the uncus from inside and from outside. And then I can go from inside, I can go into the temporal horn, and then I want to find my choroidal fissure medially. And then I'm disconnecting the head of the hippocampus. Laterally, I have the collateral sulcus, collateral eminence and collateral sulcus, which corresponds. And that's my lateral limit. That is the fimbria. And we are disconnecting the fimbria. You see the choroid plexus, and you see the basal vein deeper, and we want to see the choroidal artery, and you want to keep the arachnoid intact around the anterior choroidal artery, but you need to coagulate the vessels going to the uncus, as we said before. And when you do an operation like this, the post-op looks really nice because it's a very selective tumor resection with preservation of all the tumor around it. And that, I believe, is a more efficient approach than just crossing the temporal pole. Even more important, you're dealing with a low-grade glioma in a young patient like this with a history of seizures. And especially this is left side dominant hemisphere. So these patients will get cognitive dysfunction post-op to some degree if you do a transcortical approach, I believe. But if you do a sylvian approach selectively, you can actually, I believe, get a better outcome. It can be difficult because this case, for example, you see it has a very difficult sylvian fissure. It has, 3 or 4 veins running, and it's a very busy sylvian fissure with veins all very stacked to the other. But you don't have to give up, and if you have the skills, you can actually separate the veins and work your way into the fissure. And you will be able to get to your target, to the uncus, after some work. I remember when I was doing this case with my residents, they thought I was gonna, you know, they didn't believe you could go and open the fissure when it's that complicated, because they are not used to see these selective approaches to the medial temporal lobe. They are more used to the transtemporal approach. It's easier to go maybe transtemporal, but really, I don't think it's easy for me because I don't have the landmarks I need when I go through the brain. If I go this way, I can now see the uncus. I start seeing the uncus right here, and I can have all the landmarks I worry about. And even in a case like this, where there is a very strong vein attachment drainage anteriorly, I can dissect the vein and work around it, get enough space. Now we are finally in the uncus right here. And that's some of the tumor. And that was a large PCOM, and this is the third nerve. So some of the tumor that is growing outside the uncus. And again, I have my lenticular stereo arteries very well identified, and they form my roof. And it's very important to be very meticulous with these lenticular stereo arteries. This, I am not sure yet whether they are going to the uncus or to the anterior perforated substance. So you need to, before you coagulate them, you need to make sure they are going to the uncus and not turning around into the anterior perforated substance. Usually, medially is lenticular stereo arteries, laterally is to the uncus. Once you get to the uncus, things becomes much easier because now you start gaining a space. As you remove the uncus, you get to the amygdala. You find the third nerve anteriorly, you find the anterocoroidal artery, and that is the branch from the anterocoroidal artery to the uncal sulcus. We are coagulating. But I need to get a bit more posterior, for which, as we did before, we have to mobilize this early temporal branch and work around this branch. So you have to be careful with those branches, and sometimes they can get into a spasm. So you need to use some nimodipine or papaverine, depending on your preference. Selectively coagulated now, those were MCA branches. And now we can see the choroidal artery, the basal vein, and the choroidal fissure here. And I find the optic tract, as you see right there, my upper limit, my reference, the choroid plexus posteriorly. And now when I see the choroid plexus, I know that I'm already in the body of the hippocampus, and I have completely removed the head of the hippocampus where the tumor was located. And again, this is a beautiful operation to do, and you get a nice post-operative view of this lesion with selective removal of this tumor and preservation of the neocortex around the tumor. Now, when tumors extend more posteriorly into the body of the hippocampus, they become more challenging. And this is an example of a pan-hippocampal tumor in a patient that has nearly normal neuropsychological testing, presents again with seizures. So a tumor like this, I don't think it can be removed in one single stage because it expands all the way to the posterior segment of the medial temporal lobe. And you have to plan these operations in a way that you would do it, you want to do it in 2 stages. Again, some surgeons propose to do this in a transcortical way, but you see at the post-op pictures down here, there is a lot of temporal lobe that has been removed in order to get this hippocampal tumor out. And if you do this in the left side, even if you do it with mapping and you think you preserve language function, you are taking out of normal tumor, normal brain that is not tumor, and that, in my opinion, should not be removed. Using mapping to remove normal brain to get access might make sense, in my opinion, in some areas like the posterior superior insula, where it's difficult sometimes to get access. So getting an opercular resection in that area makes some sense. But in an area like this, you can get good transsylvian access. I don't think, at least I don't like to do myself. So this is again the view of this hippocampal tumor, and I don't need to do mapping for this tumor because I'm going to go transsylvian, and the temporal cortex is going to be lateral to my approach. And the tumor has actually created some space for you to work as you get into the ventricle. And you can see the vascular anatomy in this case. You can see a very large basal vein draining. And you can see how the temporal horn can be used as an avenue to get into this tumor. We can do pre-op fiber tracking, and this shows the fiber tracts that are around the tumor. but they are not in your way if you come from a transsylvian approach. If you come to a transcortical approach, you're going to disrupt some of these fibers. And you see all the fiber tracts that surround this tumor. They are all superficial to the hippocampus, but if we come transsylvian, we'll be able to preserve this tumor nicely. So in this case, we've opened the fissure already. This was an easy one to open. You see again our approach going to the uncus, going to the amygdala. You can tell when you get to the amygdala, it's a bit more greenish, a bit different consistency. You can see it deep there. That is the amygdala right here. And once I see the amygdala turning posterior right here, you are in the temporal horn. And then I need to have my landmarks laterally, collateral sulcus, medially, the choroid plexus, choroidal fissure that you see right there, anteriorly, the third nerve, superiorly, the optic tract and the lenticulostriate arteries. And again, we very often have to skeletonize this early temporal branch. And then I disconnect all the way. I see the tentorium because I'm disconnected along the collateral sulcus, my lateral disconnection. Now, and the bulking sum of the tumor to facilitate dissection. You can see the third nerve and the PCA. I'm doing the extra extrinsic work. And now again, finishing my disconnection of the fimbria medially. And I try to keep the arachnoid to protect those vessels. I think that's important for the choroidal artery and some other perforating branches. And this is the final disconnection of the fimbria. And you can see the choroidal artery right here going to the choroid plexus. And this is what remains of the fimbria and that tip of the uncus more anteriorly. And this beautiful white is the brainstem, the cerebral peduncle. And as you go above, you will see the optic tract. You can see nicely both the anterior choroidal artery and the hippocampal vein and the choroid plexus. Now, how do you get more posterior? I think it's important to have a good head position and a good orientation of your microscope so you can look posteriorly. And now we're looking all the way to the uncus without having to extend or incision along the inferior insular sulcus too much. This patient actually will get a quadrantonopsia, very likely, because we're getting more posterior, but that's a relatively mild deficit. And then we can continue removing all the tumor in the body of the hippocampus all the way to the atrium. I cannot work in the atrium, but I can get up to that level. And you see right there, you see the atrium, that was the tail of the hippocampus. I can tell I'm in the atrium because I can see the bulb of the corpus callosum and the calcareous. And you see the temporal bridging veins have also been preserved. So this patient did very well from this first stage. He got some naming difficulties for just a few days, but those are transient. It's just because of your mobilization of the temporal lobe. But you see post-op fiber tract in there. Fiber tracts are mostly intact. The arcuate fasciculus is intact laterally, and most of the optic radiations are preserved. And you can see the comparison of before and after, how the vast majority of the fiber tracts have been completely preserved with a good tumor resection. Now we can see the post-operative view again, and this is 8 weeks post-op, and I'm planning to take him back to the OR for a second stage. This was planned. You see the nice tumor cavity and the neocortex preserved laterally, but there is a little bit of tumor left in the posterior aspect of the hippocampus, as you will see here. And this tumor is in the ambient cistern and also pointing towards the quadrigeminal cistern, and is in this area right here. So actually, when I presented this at Tumor Board, they recommended radiation for this. And I actually disagreed, and I said, I think it's better. I talked to the patient, I think it's better to do a resection of this tumor. It's a low grade, and it's better to resect it completely. So instead of doing radiation. So we then proceeded, and we did a different approach, of course. We went from posterior, as has been described by Jasahil, Ture, Vandro de Oliveira, this nice supracerebellar transtentorial approach that gives you access to the middle and posterior aspect of the hippocampus. And here is doing the approach. This is in a sitting position. And you can also do this in a lateral position if you position the patient properly. But the beauty of this is, as soon as you go paramedian, supracerebellar, and you open the arachnoid, you're going to see the tumor. This is the fourth nerve down here, and the SCA. And all this is the tumor right here. And now I'm just carefully dissecting the tumor from the brainstem. But of course, this tumor does not belong to the brainstem. It just attached to the arachnoid, but you can detach it. But you have to cut the tent because you only can access half the tumor without cutting the tent. So you really need to do a good transection of the tentorium, tailored to the case. And after you cut the tent, you can access the supratentorial space and then get access to the tumor. And you're going to see a nice view of the PCA right here. This is where the PCA bifurcates into parieto-occipital and calcarine branches. And deep, you can see the basal vein of Rosenthal as it approaches the vein of Galen. And after you have surrounded the tumor, you can start debulking it, and that will facilitate further dissection of the tumor from the brainstem surface and all the microvessels, so we can carefully dissect this tumor completely. Now, always a challenge is the parieto-occipital artery that is in your way, and you need to dissect it very carefully. You can take the branches that selectively go to the tumor, but you need to keep the main vessel intact and make sure there are no in-passage vessels that you need to preserve. But with careful technique, you can esclerotonize the artery. You can see the basal vein. Very nice view of this anatomy. I just believe, as Julio said, the anatomy of the medial temporal lobe is one of the most beautiful in the human brain. And this is a type of operation that I really enjoyed. And at the end of the resection, we're opening the atrium, but now from posterior. And that tells us that we have completed the tumor resection. And this is actually an easy craniotomy. It's paramedian. You only expose one transverse sinus, but it's very important to expose a transverse sinus in your craniotomy so you can actually put a stitch in the tent and get some more extra space. And this is the postoperative MRI of the patient with a complete tumor resection. Again, using the anatomy to perform this type of tumor resection, as Professor Vandro showed us, the art of microneurosurgery applied to tumors of the medial temporal lobe. Thanks very much. I will be happy to take any questions or comments if anybody want to make any comments. If not, we'll jump to our next speakers.